Hello, I'm Bert Chen. I'm a urologist with Georgia Urology here in Atlanta, Georgia at DeKalb Medical Center. Today I'll be giving a talk regarding a prostate cancer update regarding prostate cancer screening, chemoprevention, and the latest treatments in terms of prostate cancer, including surgical treatment options, including a robotic laparoscopic assisted radical prostatectomy. Before the talk, I'm just going to give a brief demonstration of the robotic system. This is the Da Vinci robotic system that helps aids us perform robotic laparoscopic prostatectomy. This is our operating console that consists of the eyepieces where the operating surgeon will actually view the inside of the pelvis, as well as the master control handles and foot pedals that allow me to control the robot in terms of both action and camera and cautery of the instruments. This is the robot itself. It has 4 operating arms, including a camera arm and 3 operative arms that control different instruments within the body. These arms are introduced through port sites in the abdomen of the patient. These are facilitated by small incisions in the patients, anywhere from 1 centimeter to 1.5 centimeters, compared to an 8 to 9 centimeter open incision from a traditional open prostatectomy. Once the ports are introduced into the abdomen, air or carbon dioxide is inflated to allow a working space. The camera allows great magnification and good visualization within the pelvis itself to really allow good, precise dissection, as well as removal of the prostate and preservation of key portions of the anatomy, including the neurovascular bundle and the urethra that are important for urinary continence and sexual potency after the radical prostatectomy. I'm going to sit down at the console now. The robotic system is different than conventional laparoscopy in that the instruments have wristed jointed movement. Instead of a conventional laparoscopic instrument that can go in and out, rotate, open and close, the EndoWrist with the Da Vinci system actually allows rotation in 540 degrees of motion to mimic a human wrist to allow better dissection and more precise suturing. For example, you take a suture and you can turn the needle to place that suture exactly where you'd like, pass it to yourself, and suture as if you're repairing or putting together a urethral anastomosis. You can also tie laparoscopically. And even cut the suture yourself. Some of the advantages using a robotic system would include comparable outcomes in terms of both oncologic outcomes for prostate cancer patients in terms of achieving cure of their disease, as well as comparable functional outcomes, preserving the neurovascular bundles that will help to preserve sexual potency after the surgery, and faster recovery of continence afterwards in completing the urethral anastomosis and preventing urinary incontinence after the surgery. There's significantly less blood loss using the robotic system compared to the traditional open radical prostatectomy, and that can really aid in terms of the speed of recovery after the surgery. Even though this is a laparoscopic, minimally invasive technique, it is still major surgery, and there is a period of recovery. However, with less blood loss and smaller incisions, that recovery time can be shortened and minimized. Tonight I'm really going to kind of give it a little bit of an update on prostate cancer. A lot has come out recently about prostate cancer screening. What is the screening criteria? Is it beneficial? There's been stuff about chemoprevention of prostate cancer that's out in the news. And then, of course, an update on the treatment of prostate cancer. There have been advances in a lot of different areas in treatment, both with radiation and surgery. Tonight I'll be talking about surgical advances, the use of laparoscopy in prostate cancer treatment, and robotic prostatectomy in particular. Just to start off, what is the prostate? It is a male sexual gland. It is in the pelvis. It is about the size of a walnut. It is next to the bladder and the rectum. It makes the fluid for nutrients as part of the semen for the sperm. It produces that semen during ejaculation. The urethra is the tube that connects the bladder, drains through the middle of the prostate, and then out for both urine and semen. Prostate cancer is when those cells in the prostate grow out of control. The prostate is made up of glandular cells, stromal cells, tissue like that. If it becomes abnormal, it can become cancer. If it's detected early, it's contained within the prostate. It can spread and invade local tissues. And of course, if it gets beyond that, it can go to local lymph nodes and also to distant parts of the body, such as the bones. Prostate cancer is the most common cancer in American men. The American Cancer Society estimates over 192,000 men will be diagnosed in 2009. Over 27,000 men will die of prostate cancer in 2009. That being said, prostate cancer tends to be a more indolent cancer compared to other cancers. It only accounts for about 10% of cancer-related deaths in men. 1 in 6 men during their lifetime will be diagnosed with prostate cancer. However, only 1 in 35 men will die of prostate cancer. In part, that reflects some of the more indolent nature of prostate cancers, and some of that reflects the ability to detect the cancer early when it's still treatable and curable with either surgery, radiation, and things like that. Is it possible to prevent prostate cancer? That is a very common question that men have in terms of, can I change something in my lifestyle, in my diet, to try and keep me from getting prostate cancer? Are there dietary changes? Are there herbal supplements that I can purchase and take? Antioxidants, exercise, weight loss, or even medications? There's a lot of things in the literature that you may hear from herbalists or holistic medicine or from local health supplies about antioxidants, things like vitamin E, C, D, lycopene, which is found in tomatoes, selenium, which is a mineral which is considered to be an antioxidant, allium vegetables, garlic, onion, scallions, things like leeks, soy isoflavones, green tea polyphenols, and pomegranate juice. A lot of these things have industry-sponsored studies to suggest that they might decrease prostate cancer based on its antioxidant properties. There are some good randomized studies that are done by multi-institutional studies that have been published recently that unfortunately did not show a prevention benefit. There are 2 big studies that were published recently in JAMA earlier this year that looked at vitamin C, E, and selenium, and they did not, unfortunately, prevent prostate cancer. In fact, one of the studies was stopped early because there was concern for an increase in prostate cancer for some of the subjects. What about weight? What about eating healthy? What about things like that? Body mass index is one way to measure your weight, body fat and obesity based on height and weight. There is evidence in lots of different studies that the higher the BMI or body mass index, it is a risk factor for more aggressive prostate cancer. And so, like other health professionals, like your cardiologists and things like that, we typically recommend trying to maintain a healthy weight, to eat a diet low in total fat, saturated fat, polyunsaturated fat, things like that. Not to say that you have to lose all the weight, but certainly maintaining a healthy weight and personal level of fitness can help prevent prostate cancer. What about other medications? There is some evidence about statin drugs. Statin drugs are a class of medications that men take if they have elevated cholesterol levels. This has been found to be associated with a lower risk of advanced prostate cancer. The reason for this is not entirely clear. There's felt to be some anti-inflammatory properties of the statin medications that might end up benefiting prostate cancer, but a clear relationship is not established. So right now, we're left with this question. We see this relationship, but we're not sure whether or not these statin drugs actually reduce prostate cancer. What about medications for prostate enlargement? Benign prostatic hypertrophy is a common growth of the prostate gland in a benign fashion. It is common in men as they get older. The older you get, the larger the prostate grows in benign fashion. It usually manifests itself in terms of urinary symptoms, slow stream, getting up at night, all the things that you see in the advertisements for Flomax and things like that. There are medications that will physically shrink the size of the prostate by lowering the testosterone levels in the prostate. These are Proscar and Avodart. Now, these have been studied with a hypothesis that if you lower the active form of testosterone in the prostate, that this might actually prevent the development of prostate cancer, and there's some good scientific backing for that. There have been 2 large, randomized, well-controlled, multi-center studies in the United States that actually do show that men who take Proscar and Avodart over a period of time, in one study 4 years and another study 7 years, that there was an actual decrease in the incidence of prostate cancer up to about 24% over that period of time. Now, that's very encouraging, but these medications right now are still only for benign prostate disease. There's no FDA approval for prostate cancer chemoprevention. But it is very exciting that there are some medications that can kind of provide that for us. And some men may be candidates to start on this medication depending on the size of their prostate and their symptoms. There are some side effects, of course. Sometimes these can be sexual. And in one study, there was a concern for the possibility of the men who did develop cancer while on these medications that they get higher grade cancers. That has not been shown to be causal, but is certainly one point of concern. So what about prostate cancer screening? When do we start prostate cancer screening? When is it appropriate? And who should get screened? PSA is a blood test. Prostate-specific antigen is what that stands for. It's a protein that the prostate makes. It was discovered in the 1970s. Starting in the late 80s and early 90s, it became more widespread as it used for the actual screening to detection of prostate cancer. Over that time period, throughout the 90s and 2000s, we see that as PSA screening becomes more widespread, we also see that the prostate cancer death rate drops. Now, are those two connected? Is the increase in PSA screening related to the decrease in prostate cancer mortality, or is it really just a result of improvements in our treatment with surgery or radiation? Is it because people are eating better, eating more, having more antioxidants, or maybe because of the statins or other medications that are kind of available? It's not entirely clear. In fact, 2 studies recently, one from Europe and one from the United States, suggested that PSA screening may not be the end-all be-all in terms of reducing prostate cancer mortality. I think that's still under debate. It has certainly garnered some media attention in terms of whether or not every man should get PSA screening or not, and the U.S. government has actually changed some of their recommendations as to whether or not it is appropriate for every man to get PSA screening. What is involved in terms of prostate cancer screening? Typically, it involves 2 different tests. One is the digital rectal exam, where you actually have a finger in the rectum to palpate the posterior portion of the prostate to make sure that it feels normal, that there are no hard spots or nodules, and then the blood test, which is done in the office, called the PSA. If either one of those tests are abnormal, that can sometimes prompt enough concern to proceed with a biopsy. Neither test will diagnose prostate cancer by itself without a biopsy. So the question remains, who should be screened? When should we start screening? And possibly, when should we stop screening as men get older? This will be determined by a patient's personal preference, the conversation that you have with your doctor, and then the family history and race. Men who have first-degree relatives with prostate cancer, a brother, a father, something like that, are at more risk for prostate cancer. African Americans tend to be at higher risk for prostate cancer compared to Caucasians and Asians. The American Cancer Society and the American Urologic Association recommendations have always been, starting at age 50, annual digital rectal examinations and PSA tests. Now, that has changed somewhat over the last year because of this new data regarding the benefits of PSA screening. It should be recommended for men after they have a conversation with their physician as to the risks, benefits, and potential shortcomings of PSA testing. It is not the end-all be-all. We typically recommend screening for men who are well-informed, who want to look for cancer early, and to consider starting as early as age 40, not necessarily every year, but at least to get a baseline digital rectal exam and PSA, and then determine the interval of testing after that based on the patient's personal risk and what their initial PSA level was. The U.S. government, through the U.S. Preventative Services Task Force, actually does not recommend prostate cancer screening and actually recommends against screening for men over the age of 75. And what they state is that there's not enough benefit demonstrated to recommend screening for men over the age of 75. This is not probably an overall statement that would apply to every man over the age of 75. Certainly there are some men over the age of 75 who are in very good health, who have life expectancies based on their medical health of more than 10 or 15 years, who may want to continue pursuing prostate cancer screening in spite of the risks of diagnosing indolent cancers. That is something that is based on a personal preference and can be decided upon after discussion with their physician. Typically, the best prognosis with prostate cancer is if you detect it early, when it is localized. It affords you the most options for your treatment. There is data that suggests that there are lower mortality rates for prostate cancer for obviously lower stage, earlier discovered cancers. And there is some treatment benefit that has been seen in studies when you compare surgery versus watchful waiting or just active surveillance. Typically, if you undergo a biopsy, with the biopsy results, if they find cancer, they grade it with a pathologist. There's a Gleason grading system that ranks it from 1 to 5, 1 being least aggressive, 5 being most aggressive. You add the two most common area scores together for a sum that will be between 2 and 10. 6 and below is low grade, 7 is intermediate, 8, 9, and 10 are considered high grade. When you stage prostate cancer, you look at the PSA diagnosis, what the prostate feels like on the exam, and what the Gleason score is. If there is enough concern for high PSA or high score, you may end up having also a bone scan or CT scan to kind of help stage the disease to make sure there's no evidence of soft tissue or bony metastasis. Prostate cancer staging starts with tumor, what it feels like on the exam. A T1 cancer can't be felt. T1A and T1B are more historical when people were doing a lot more transurethral resections of prostates. Most men, or a majority of men, who are diagnosed now is just because of a result of a PSA elevation, T1C, you can't feel the prostate, the PSA was just abnormal. T2, you can feel something on the rectal exam, but it still feels confined to the prostate. T3, you can feel something, but it feels like it's spreading beyond the prostate, either right beyond the capsule or invading some of the local things like the seminal vesicles. And T4 is more advanced cancer. It's spread to the local organs, i.e. to the bladder, to the rectum, to the surrounding pelvic sidewall. At this point, it's pretty advanced disease. It may even cause pain in joints and back, whereas other earlier disease may be completely asymptomatic. T4 prostate cancer is more rare now with PSA screening. What are our treatment options? Well, this does depend on our stage of disease, what your patient age is, your health at the time, and of course the patient's personal preference. Some people will have strong preferences towards one treatment modality or the other, whether radiation or surgery. Options include watchful waiting, which is also called active surveillance, radiation, surgery, and then alternative therapies such as cryotherapy or high-intensity focused ultrasound. These are all treatment options for localized disease, cancer that is still confined to the prostate. Hormone therapy and chemotherapy are also treatment options for prostate cancer. However, these are typically reserved for cases of prostate cancer that is more advanced, spread from the body. Hormone therapy and chemotherapy are typically not curative. They are more palliative in terms of trying to control the disease. Watchful waiting. Some of the advantages of it would be that it's obviously not very invasive. You avoid any of the potential side effects of the treatments, other treatments, but there is some measure of uncertainty. It's hard to predict what that prostate cancer will do over the course of months to years under surveillance. Will it stay confined to the prostate? Will it grow and spread? Will it leave the prostate to go to other parts of the body? Radiation is a treatment option. Its advantages include a more minimal recovery. It has a long track record of good cure rates. It has a slightly lower risk of incontinence after the treatment. Disadvantages: after your treatment, the PSA will not go down immediately. There will be some fluctuation of the PSA over the first 1 to 2 or 3 years after the radiation treatment. You still can have some initial or long-term urinary and bowel side effects that include things like irritation, burning, or even blood in either bowel movements or urine, and possible erectile dysfunction. Radiation methods include external beam radiation, proton beam, which is only available at certain centers, brachytherapy, which is also known as seed implants, and high-dose radiation or HDR therapy. Surgery also probably has a lot of advantages. It has probably the most information. We've been doing surgery for decades. There's been an evolution in technique, a refinement in technique to improve cancer outcomes and also to improve functional outcomes. It is well established with documented cure rates for localized disease, and it does give some emotional edge. You were discovered to have cancer in your prostate. You have the surgery, the entire prostate and all the cancer is removed. You have an immediate decline in your PSA to undetectable to know that all the prostate tissue is gone. Disadvantages, it is a major surgery. Regardless of whatever type of technique is used, it is still a major surgery. There is the potential for blood loss. There is a recovery period of time when you're healing from surgery. There is the risk of urinary incontinence or leakage after the surgery when the catheter comes out. There is the risk of erectile dysfunction afterwards. Cryotherapy is freezing the prostate. You leave the prostate in the body, you kill it in situ in the body like radiation. The advantage is it freezes or kills the cells right away. If you miss some, you can go back and freeze again. Disadvantages, it is not as well established. It has some possible urinary side effects, the possibility of erectile dysfunction and leaving residual prostate tissue. However, it can be a very effective treatment in the right hands. High-intensity focused ultrasound is also an energy technique to burn the prostate cancer using ultrasound waves. It also ablates the tissue. You can retreat it, possibly has a lower side effect profile. It's being used more in Europe. It is starting to be established here, but it also is more investigational at this point. It also still has some of the side effects. What about surgery? This would be considered radical prostatectomy. There are different prostate surgeries. Some prostate surgery is for benign disease where only a portion of the prostate is removed to allow improvement in urination flow. This would be removal of the entire prostate with the objective to cure the cancer. You can do open surgery, a laparoscopic surgery, or a robotic-assisted laparoscopic surgery, and that's using the Da Vinci robotic system, which you saw upstairs. In the past, radical prostatectomy was really felt to be a pretty morbid procedure. Lots of side effects, risk of a blood loss, difficulty of recovery. Over time, there's been a significant improvement in the surgical technique. Even if you have an open prostatectomy now compared to 10 years ago, the blood loss tends to be less, the functional outcomes tend to be better, the hospital stay tends to be shorter. The goals, of course, are to remove the entire prostate and the cancer, to achieve a high rate of cure, to preserve the urinary function, preserve the erectile function, and to provide as much information about the prostate cancer as possible. You remove the entire prostate, you have all that tissue to give to the pathologist. The pathologist is able to go through the entire thing and to make sure that they know the exact extent of disease and grade of your cancer. There is an upwards of 20 to 25% rate of upstaging or downstaging once the pathologist has all that information compared to those small little slivers from the prostate biopsy. If this surgery is successful, we expect to see an undetectable PSA as early as 6 weeks after the surgery. Laparoscopic surgery is a minimally invasive technique to do the same surgery on the inside using smaller incisions on the outside. We operate through 5 or so small incisions, about 1 to 1.5 centimeters in size. A camera and the instruments go through these little incisions, and you have very good visualization, almost better than open surgery, just because of the position of the male pelvis. The benefits are the angle of approach. You look directly into the male pelvis, which tends to be more narrow than a female pelvis. You have good visibility with the use of the camera, and you have access to the prostate both above and underneath, heading in an antegrade fashion. There are some drawbacks. When you operate laparoscopically, you're operating off of a TV monitor. It's two-dimensional flat image. The instruments are rigid. They're like long chopsticks, and you're working at a distance through a fulcrum of the body, and it decreases your ability to control it precisely, and it does increase the surgeon fatigue in terms of trying to do this surgery. It takes longer. It makes the surgery a little bit more difficult. We can overcome those drawbacks using a 3D high-resolution image. We can get a more instrument tip that has a little bit more dexterity, and that's what the robotic system actually allows us to do. So what is the Da Vinci surgical system? It is a state-of-the-art robotic technology that allows us to perform laparoscopic surgery with the assistance of a robotic interface. The surgeon is actually sitting at the operative console that controls the arms for the robot, and the assistant surgeon is at the bedside. This kind of shows a couple of the different components, including the operative console, their eyepieces and control arms, as well as foot pedals, the robot itself, the surgical arms, which are tiny, and then this kind of shows the different interface there. In the operating room, its setup is similar to this: patient at the bedside, assistant, nurse, and anesthesiologist, robot with the patient, surgeon at the console. The vision system is three-dimensional. You have You put your head into these eyepieces and you have stereoscopic 3D vision. You have excellent magnification and visibility. Typically, the blood loss for a laparoscopic robotic prostatectomy is much less. That helps maintain a blood-free field to allow better visualization, and you have an excellent angular approach towards the prostate into the pelvis from above. The surgeon controls the instruments. The robotic arms do not move without the direction of the surgeon at these control arms. If the surgeon's head is not in the operative console and his hands are not operating this, the robot does not move independently. And what that looks like is this. You can see the wristed motion of the robot mimics the motions of the fingers and wrists of the surgeon to allow for precise placement of suture. And this is different than conventional laparoscopy. Conventional laparoscopy can go in and out, it can twist, it can open and close. It does not move in a wristed fashion. And the EndoWrist instruments, all of them, allow you to have much more freedom of motion there. And what that looks like in an operation, if this is the bladder and we're sewing down to the urethra, typically this is a very tight, narrow space. It is in two different planes of suture. And as you can see, using the wristed joints, you can twist and turn and follow that in there just so to kind of get that suture placed. Now, these instruments are very small. They fit through 8-millimeter port sites. A very large array of instruments are available, and certainly enough to do prostatectomy. The comparison in the past, and this is probably a little bit long. I mean, as surgical technique has improved, the incision does not reach all the way to the belly button. But an 8 to 9 centimeter incision from about here down to the pubic bone compared to 5 or so small incisions along there in terms of recovery. So what are our advantages? Well, definitely decreased blood loss compared to open prostatectomy. An approach where we go forward, going down towards the prostate and the rectum in an antegrade fashion. Typically, the hospital stay is shorter with a robotic prostatectomy. 1 day is most common. Most of my patients go home the following day after surgery compared to 2 or 3 days after open surgery. There is typically less postoperative pain initially. However, I will say that it's not painless surgery. It is still major surgery where cuts are made. There is typically less scarring, a shorter catheter time, and oftentimes faster return to regular activities. And we are hoping for, of course, good functional return of urinary continence and erectile function after the surgery. In summary, prostate cancer is the most common cancer in men. Prostate cancer prevention is still under investigation. There are a lot of promising things in terms of diet and medication, some proven, some not so much. Nothing definitive yet, but still under investigation. Prostate cancer screening in appropriate men can provide early detection, and of course, early detection can be the key to a curative outcome. There are a lot of treatment options that are available, including surgery, and if you find yourself in that situation, please have a conversation with your physician and your urologist. Thank you very much. Any questions? It is, in part, in terms of trying to determine the aggressiveness, we look at a couple different things. We look at the stage, which is that T-score that I was talking about. We look at how high the PSA is at the time of your initial diagnosis. Is it less than 10? Is it less than 20? And the Gleason score does provide a lot of diagnostic information because the pathologist examines the biopsy and looks at the cells to say, does this look like an aggressive cancer? Now that being said, the biopsies are very small slivers of tissue, and they don't provide an incomplete picture of the entire prostate. If there's cancer there, like I was talking about, if you have a prostatectomy and the pathologist has the entire prostate to look at, there can sometimes be adjustments in terms of more aggressive disease, less aggressive disease, bilateral disease instead of just one side. That's information that you won't get until after the prostatectomy. The prostate is completely removed, and the goal is, of course, leaving no prostate tissue behind. Unfortunately, some prostate cancers typically the more aggressive prostate cancers, can break free and escape from the prostate even before surgery at the time of diagnosis. And unfortunately, some of that microscopic escape of the prostate cancer may not be able to be detected at the time of surgery. Even if you were to do CT scans and bone scans, they may be negative because you can't find microscopic disease. That you won't be able to tell until after you follow that over a period of time. So in men who have, say, Gleason 8, 9, or 10 high-grade cancers, some of them may have microscopic disease outside of the prostate. And so once the prostate is removed, you may not expect to have a local recurrence, i.e. in the pelvis where the prostate used to be, but years down the road, could the PSA come back up? Could there be evidence of cancer someplace else? Unfortunately, the answer is yes. It is. I will have a caveat about PSA, which is to say that it is an excellent tool for screening and detection of prostate cancer, but it is not a perfect tool because even though it's prostate specific, it is not cancer specific. So there are other things that can cause that PSA to fluctuate up and down, including benign things like prostate enlargement, infection, or inflammation of the prostate. There are different ways that we have used to try and manipulate that PSA number to try and give us a better sense of whether it represents cancer or if it represents benign disease. Using the percent-free PSA helps us with that. So if you have a PSA level between 4 and 10, which is kind of in a gray zone, is this cancer, is just prostate enlargement, that percent-free PSA number may give us a little bit more information to kind of tell us which way we're leaning, okay? But it will never make the diagnosis of cancer. So if you could have a PSA between 4 and 10 that was kind of in the gray zone, not sure, you get the percent-free PSA. If you have a percent-free PSA that's very abnormal, certainly that would prompt more investigation with biopsy. If it's more normal, then you may feel more comfortable watching the PSA. That percent-free PSA may also fall in that gray zone. And then you have to have the discussion as to say how aggressively you want to pursue it. Typically, we do want to find, at this point, we do want to make a tissue diagnosis, i.e. get a biopsy, get the tissue to the pathologist, have the pathologist look at it and say, yes, this is prostate cancer, before we undergo any kind of aggressive therapy such as surgery or radiation. Now, all the time we're trying to push the forefront in terms of trying to minimize the invasiveness of our testing to find prostate cancer, because a prostate biopsy, unfortunately, is an uncomfortable, invasive test. But at this point, you know, the blood tests that we do, the X-ray tests that we do, even like things like endorectal MRIs, they're not good enough yet for us to not have to do a biopsy to make the diagnosis. That's a very good question, because that is part of the whole purpose of trying to kind of improve our technique. You know, back when they first started doing the prostatectomies, incontinence was very commonplace. As we've improved our understanding of the anatomy, the male anatomy, the urethral sphincter, the prostate in relationship to that, preserving that, doing our anastomosis, the continence rates get better and better. Now, most men wear their catheter after the surgery for about a week or so. Once the catheter comes out, there is a period of time, sometimes for a few weeks, sometimes for a few months, where the urinary control is not good, and you have to wear a pad. And during that time, the patient or the man can practice doing pelvic floor exercises to try and strengthen that muscle to make their recovery a little bit quicker. Some men regain their control as early as the first month. Some men, it takes as long as a year. And in a very small percentage of men, they never gain complete control and may need a secondary procedure to get that control back. That's under investigation. There are a couple of sites, academic centers in the United States and Canada, Toronto, Johns Hopkins, a couple other places, where men who are not good surgical candidates or even other treatment candidates who are older, who have bad health, who don't want to have anything done, watch their cancers. And typically, for enrollment in that, you have to have lower grade, smaller volume disease, i.e. Gleason 6 and below, only 1 or 2 cores, only a certain percentage of those cores involving cancer, to be even candidates really for that active surveillance protocol. Now, those guys are monitored pretty aggressively. PSAs on a regular interval, 3 months, 6 months, and then even periodic biopsies, meaning doing a biopsy once a year just to make sure that there's no progression in terms of the amount of cancer or the grade of cancer. The data is still collecting on that, whether that's going to work out. You know, in older men, in select men, I think it's very reasonable. However, there is some emerging data that suggests that perhaps for younger men, their cure rates might be slightly smaller, even though they're getting treated with intention to cure after they've waited compared to immediate therapy. But the data is really too early to say about that. You would expect it to be the same stage for stage, meaning T1, T2, T3, Gleason scores and things like that. So typically, when you look at cure rates for these different modalities of cancer operation, prostate cancer is one where cure rate is harder to look at because even after you have a recurrence, the time from prostate cancer recurrence to actual death can be very long because prostate cancer is more indolent. So oftentimes what studies use to kind of look at cure rates are markers like PSA recurrence, time to metastasis, not actual death, because we don't have enough study time where we followed somebody for 20 years to see them have their surgery, recur, and then ultimately make it to mortality. The other issue is that there's never been a study to compare head-to-head, say randomized, radiation versus surgery in the United States, and they probably never will because really, truthfully, American men would probably not be very interested in randomizing to say, well, we don't know what you're going to get. You're either going to get surgery or radiation. We won't find out until you enter the study. But when you look at comparable studies that are well done, matching Gleason grade and stage, radiation and surgery cure rates, stage for stage, grade for grade, are very similar. And that's to say that both are excellent treatments, both offer a very good rate of cure. The difference oftentimes is what side effects that the man is willing to undergo having had their treatment. And that comes into the personal preference part of what we were talking about. If you're diagnosed with prostate cancer, you have to look at how you feel right now. You may not have any symptoms at all, but then after surgery or after radiation, you might have symptoms or side effects from the treatment itself to get the cure for the prostate cancer. And what you're willing to undergo as potential side effects will affect your decision in terms of what treatment that you want to undergo to kind of try and cure your cancer. Thank you guys again for coming.